Thank you, sir. And I will quickly cover capsulorhexis techniques in children. So this is one routinely what we do is after initial staining. Again, in children, staining is important because the elasticity comes down to a large extent. And even if you have a good red glow, it is always better to stain in children. One of the instruments that can be used is a microrhexis forceps, and microrhexis forceps can be either with the side port or main port, whatever we are comfortable with. And trick is to grip and re-grip while doing the anterior capsulorhexis. And posterior rhexis, more or less, I have switched to cutter. And I no longer do a manual posterior capsulorhexis. I just use a high-speed cutter, 23 gauge cutter, to do a round posterior rhexis. And after that, if it is a smaller than the anterior capsulorhexis, you get a well-centered in the bag IOL, and which is 100% in case of vitrector rhexis. If you are doing it manually, sometimes it may you may lose the rhexis and then may have to place the bag in the sulcus, lens in the sulcus. So this is one case. And next, what we see is what is the other way we can do it. Again, here you see the anticapsule has been stained. Initial nick with cystitome. 2.2 or 2.8 millimeter incision, depending on what. And what you see here is the utrata forceps. So initially, one instrument that was used was microrhexis forceps. Another option is a utrata forceps, by which we can do it. And in this was a case of deficient posterior capsule. So after the IOL implantation, just open up in that area and enlarge the posterior capsular opening using a cutter. So another important way we can do it is when you have fibrosed anterior capsule. And here what we see, once the initial nick has been made, and through the non-fibrosed area, we try to go as far as we could. And once there is obstruction, there is no point pulling it further because it will extend to the periphery. And at this point, we have to go in with a cutter and trim the rest of it. So main aim is a good around 5 to 5.5 millimeter opening in the anterior capsule, which facilitates IOL implantation in the bag in children. So now with cutter, we are extending, and with the new cutters, 23 gauge, and a lower cut rate, maybe around 1200 or 1500 cut rate, it cuts the membranes very easily. High cut rate may be a problem in thick membranes. And keep trimming till you get a adequate sized anterior capsular opening. And what you see here is a very good round edge, and once the lens has been implanted, posterior capsulorhexis using a cutter itself. So again, we were able to place the lens in the bag due to this technique, and this is the pre-op and post-op picture of the same. Thank you so much.